Happy birthday. Thank you. So these are my disclosures. So the C9, as I mentioned earlier, the C9ORF72 mutation is a hexanucleotide expansion that causes FTD and ALS. This mutation was discovered in 2011, and that discovery came out of work that was done in the labs of Rosa Rademakers, who's now in Belgium, and Brian Traynor, who used to be in our neurology department here, collaborated closely with our neurology department here, and is now at the NIH. So this repeat expansion, so the normal gene, which you see on the left side of the slide, has three variants that are typically three splice variants typically. The abnormal gene has a hexanucleotide expansion from about, typically we would say normal should be well below 20, well below 30. And in the original cases that led to the discovery, the repeat expansions were hundreds, of 700 and above. It still remains clear as to where exactly to draw the cutoff, and the correspondence of repeat length to things like anticipation, age at onset of illness. And for those who don't know what anticipation is, the idea that in successive generations the disease comes on early in life. So these associations have not been well established, although some studies have suggested anticipation with no sex difference. Some studies have suggested an earlier age at onset. Now, in the lower part of this panel shows you some things about the mechanisms. They're believed to be a combination of a loss and a gain of function. The loss of function has to do firstly with sequestration of RNA binding proteins, so that's one. The toxic gain of function has to do with the production of dipeptide repeats. So these are poly-GP proteins, polyglycoproteins. And then there's also antisense translation, which of course is what leads to these hexanucleotide repeat is what leads to these dipeptide repeat proteins. Now, there are other major genetic loci for familial frontotemporal dementia. The C9orf72 is believed to be the most frequent. It does not account for the majority of all, but it definitely is the most frequent, alongside the mutations of the progranulin and tau genes. It turns out that mutations on both progranulin and tau are on the same chromosome, chromosome 17. And they're not very far apart, as you can see from the panel there. We've since discovered a smattering of other genes that account for collectively for less than 10% of all. We believe that the big three account for over 90% of all familial FTD. This list is by no means exhaustive. There's the valocin-containing protein, for example, VCP. There's the CHIMP2B mutation, which was the very first to be discovered, which is the cause of what used to be called familial Danish dementia. And then there's the optoneuron and TREM2 genes as well. Now, TMEM106B, which is a transmembrane protein, has been shown to be a modifier of the risk for dementia in carriers of the C9orf72, as well as progranulin mutation, and generally it leads to an earlier age at onset of illness. Now, turns out that the progranulin mutation is a loss of function mutation. It's a haploinsufficiency. And as a result, there are reductions in the CSF and plasma progranulin levels, which are sometimes used in lieu of genetic testing because certain kinds of mutations are easier to find this way. And so in normal carriers as well as people who are affected with symptoms, together can be distinguished from healthy subjects because the levels are diminished in both carriers, whether they're symptomatic or not, and that's what you can see in these panels here. So if you look to your right, all the way to your left, those are the normal subjects, and then the levels are diminished in both mutation carriers as well as people who are affected with symptoms. Now, the first two panels show you plasma and CSF progranulin, and then the last panel shows you that there's a tight correlation between the CSF and the plasma levels. Now, there's an uneven distribution of hereditary mutations around the world. And so most, especially with the C9 mutation, it's believed to have been founded in Northern Europe, predominantly in Scandinavia, and to have spread from there through the world. So most cases have been identified in Western Europe and in North America. Now, it turns out this map also coincides with the distribution of major centers, and so there is a bit of uncertainty regarding how accurate this is. Now, however, there is quite a bit of FTD research in Japan. There's more in China. It's not reflected on this map because this paper was published before the FTD research really took off in China. But what we know is that in Southeast Asia, the frequency of C9 mutations, progranulin mutations, is quite low. And there's a higher frequency instead of tau mutations in that locale, but not necessarily higher than in the rest of the world. We don't have any data yet in Africa, but a few years ago, a colleague of mine, Keith Josephs at University at Mayo Clinic in Rochester, and I collated basically cases of African heritage throughout the world and found that in terms of phenotypes, there were no significant differences that you would link to ethnocultural background. A few of the cases had C9 mutations, but this was a small sample, so it's by no means conclusive. We wouldn't call it representative. There hasn't been any systematic genetic research in Africa at this time. So this panel shows us the symptom probability by age in people who have these mutations. Turns out that the onset is earlier, or earliest for the tau mutation carriers compared to C9 and then progranulin. And so onset with tau mutations can begin as early as the mid-20s, and by about age 50, 50% of mutation carriers would have illness. Now, for progranulin and for the C9 mutation, the 50% mark is reached at about age 60. So by age 60, about 50% of mutation carriers will have symptoms. Now, in the clinical space, we try to predict when a mutation carrier who is currently asymptomatic, might develop symptoms. And the best indicator we have today is the mean age of onset in the family. The panels on your right show you correlations for the different mutation classes. It turns out that these correlations are best for the tau mutation carriers. It's about 60%. And they're least valuable in progranulin carriers where the age at onset is scattered, even in families. So at this time, we don't have very good predictors, really, of when a person who has a mutation is estimated to begin to develop symptoms. Now, as I mentioned earlier, tau mutation carriers tend to develop illness earlier. So these are Violin plots showing you firstly age at onset and then age at death, and giving you firstly a sense of when people develop the illness and the spread around the medians, as well as a sense of the illness duration. And so for the tau mutation carriers, the symptoms begin earliest, and then illness duration is about 10 years based on this. The illness duration, the median illness duration, seems to be a bit shorter for C9 ORF72 mutation carriers, but that probably is in part because a substantial proportion of these people actually have developed ALS rather than FTD, or they develop both conditions. Now, a couple of years ago, a postdoc working with Chiadi Onyike summarized illness duration data from all published research at the time, including for Alzheimer's disease, for all the FTD phenotypes, as well as for Alzheimer's disease cases that have been examined or have been observed alongside those FTD cases. And she showed that basically the survival mirrors what the previous slide suggested, 8 to 10 years. It mirrors what you would expect for Alzheimer's disease. So life expectancy is about the same as you would expect for Alzheimer's disease, except in the case of FTD ALS, which is what you see all the way on your left, where life expectancy is about 2 to 3 years. Now, this data, of course, did not separate sporadic from familial cases. But we would expect the sporadic cases to be far more prevalent in this data set, except in the case of FTD ALS, which those would almost certainly be hereditary cases. So, but we've long conceptualized and thought of and described the frontotemporal dementias as featuring primarily the aberrations in conduct, in temperament, in judgment. So the canonical phenotypes describe abnormalities either of behavior, social behavior, or language. And so there are three canonical phenotypes, one that has to do with coarsening of temperament, dispositions, judgment, and comportment. And these are people who also have trouble regulating their drives. So they overeat, for example. And that's a behavioral phenotype, or what we call behavioral variant frontotemporal dementia. And then you have two language phenotypes, one in which speech is effortful, disjointed, agrammatical, reminiscent of Broca's aphasia, which we call the primary non-fluent primary progressive aphasia. And then others in whom they're fluent, but the speech is vacuous, and this is primarily because they are losing knowledge of what words mean and what objects are. And so their speech is devoid of nouns. And conversely, because they don't know what nouns are, they don't also have trouble understanding what people are saying to them because they don't know what the content is. And we call that semantic dementia. But it turns out that FTD is quite clinically heterogeneous. So we, a number of years ago, looking at cases in our brain bank, identified cases with a primarily amnesic presentation, often with focal atrophy and histopathology in the medial temporal lobe structures. Now, the behavioral variant and the primary progressive aphasia variants can also occur with ALS, as I've already sort of mentioned. We also have motor-predominant phenotypes that are dominated by apraxia and or Parkinsonism. So cortical basal degeneration, primary progressive supranuclear palsy. Now, C9orf72 in up to 40% of cases, and we've seen a few examples over the years, might present with psychiatric disturbance. We've had cases that presented with delusions and hallucinations, with depression. In the literature, there are cases where the first presentation was suicidal depression. So you can have predominantly psychiatric presentations, and this leads quite frequently to misdiagnosis. And with the VCP mutations, the majority of those cases have inclusion body myopathy. And so it's dominated by myopathy, but sometimes they have Paget's disease of bone, they have FTD or ALS, or FTD and ALS and Paget's disease of bone. And similar to other FTD cases, the life expectancy varies according to the phenotype. So in those cases, the FTD, IBM, FTD, ALS has a life expectancy similar to ALS, whereas the pure IBM cases tend to go on for decades. When you look at the brain imaging, you typically will see focal atrophy, the distribution of which will correspond to the phenotype. They're also pathologically heterogeneous. I won't go into this in detail, except to say that panel A is the classic pig body, and B and C are also tau inclusion bodies. So A, B, C are tau inclusion bodies with different morphologies corresponding to different conditions. In case of panel B, that's PSP, and panel C is CBD. And then panel D has to do with FET protein inclusion bodies. FET protein inclusion bodies are rare. They're typically associated with either familial ALS or sporadic FTD of very early onset, typically beginning by age 30, 40, and with a fulminant presentation. The first three lower panels, so that would be E, F, and G, are TDP43 positive inclusion bodies. In the case of panel E, these are juxtaposed against the nucleolus, so they're intranuclear. And the other two are cytoplasmic. And it turns out that the morphology of the TDP43 travels with different types of genetic mutations. And so, for example, the mutations in VCP protein, which are also associated with TDP43, differ from those with C9 and differ from those with programming mutations. Panel H are P62 inclusion, show P62 inclusion bodies in the dentate granule cells of the cerebellum, which is pathognomonic for the C9 mutation carriers. Now, so as you're already beginning to discern, there is quite a bit of interplay between clinical phenotypes, the neuropathological subtypes, the genetic subtypes. The correspondence is not one-to-one, except that I would say that where there's FTD with ALS, it's almost certainly going to be TDP43 positive inclusion bodies. And where it's semantic dementia, it's almost certainly going to be TDP43 positive. And tau mutations are typically associated with Parkinsonism. But other than that, it's very difficult, for example, to tell if a person presenting with behavioral FTD has either tau or TDP43 as an inclusion body. Now, there hasn't been much study of the co-occurrence of the ApoE4 genotype in either genetic or sporadic FTD as it relates to the onset or course of illness. But what this panel is showing here, and I show that in a red box, is that with tau mutation carriers, the age at onset might be a bit earlier when they carry when they also when they have either heterozygous or homozygous for the apolipoprotein E4. So if they're apolipoprotein E4 positive. Now, apolipoprotein E4 positivity often results, even in people who are asymptomatic, in some accumulation of amyloid beta in the brain. But it turns out that when you look at associations, and that's the second panel on your right, with amyloid beta seems to delay or is associated with a later age at onset, whereas apolipoprotein E4 positivity is associated with an earlier onset, and when people are positive for both, and that's the middle panel, this line. When they're positive for both, it seems to cancel out, at least in this data, but these are very small sample sizes. We would consider this very preliminary, and it's in need of replication. So this study was published, I think, 5 years ago and has not yet been replicated. As I mentioned earlier, the tempo of progression can vary according to the phenotype. So we have articulated an idea that there are what we would call normal progression cases. So these would be people for whom the life expectancy is about 8 to 10 years. And there'll be those, typically FTD ALS, where the life expectancy is considerably shorter and the tempo of progression is much faster. Well, there are cases where FTD has been shown to evolve over 20, 30 years, where children, and I mean adult children, have developed illness before their parents. There are a few case reports of a C9 mutation carriers who developed the illness before their parents did. Some cases have been described in literature and identified either on the basis of histopathology or genetic analysis where illness duration is as long as 30 years. So there are some very slow progression cases. We used to refer to these as phenocopies, thinking of them as mimics, but it turns out that they actually are cases. Now, it turns out that it's not uncommon for C9 mutation carriers to, firstly, not show focal atrophy, and secondly, to have normal appearing brain scans at the time that symptoms have begun. These panels here show you atrophy trends across mutation types. So starting from your left to your right, you can see that the curve seems steepest for the tau mutation carriers, and are relatively shallow for the C9 ORF72 carriers. And this is sometimes another cause for misdiagnosis. So there tends to be pronounced frontal and anterior temporal atrophy in tau mutation carriers, and sometimes we have what is called a knife edge atrophy appearance. There's asymmetry, left-right asymmetry is common in progranulin mutation carriers, whereas it's relatively non-focal and very subtle atrophy in C9 mutation carriers. There are two large cohorts that have developed to study dementia, taking advantage of this genetic of familial FTD cases. So familial FTD makes up about 5 to 20%. We believe it's somewhere around 10 to 15% of all FTD. And so it represents an opportunity to get at the biology of this illness and begin to develop targeted treatments. And this is a concept. These are the concepts that we're working with. The panel on the left is articulated by the All FTD Consortium, which is a North American FTD consortium. The panel on your right is the GenFI, the Genetic Frontotemporal Initiative that is in Europe and parts of Canada. And it's similar, which is the idea that you go from you go from a state of normal to a state of symptomatic and to overt dementia, and that there are molecular and radiological events prior to this development of symptoms. And if we can identify those, firstly, we would have a basis for screening the population, perhaps. We would have a way to measure treatment effects in asymptomatic people, which is really what we want to be able to do. And we would have biomarkers that can facilitate diagnosis. This research, and I don't have time to go into the details, has led to identification of a variety of mechanisms, candidate mechanisms that are now the focus of disease and drug development. And these have to do with things like dysregulation of cellular repair, and which the normal progranulin is heavily involved in. Issues to do with tau polymerization and tau propagation through the cell in cases, as well as disruption of axonal transport. Now, progranulin and C9orf72 are very heavily involved in lysosomal function, in endosomal trafficking and autophagy, and protein chaperoning through the cells. And as I mentioned at the beginning, the non-ATG, or the antisense translation of the hexanucleotide expansion results in a variety of toxic proteins in addition to a number of RNA translation deficiencies. Here at Hopkins, Phil Wong and his colleagues described TDP43 repression as a natural mechanism for regulating cryptic exons, and that the loss of that repression is itself a source of the neurodegenerative process. Now, it turns out that this is now regarded as a seminal discovery, and it's beginning to be a focus of drug development efforts in the field. So, based on these candidate mechanisms, we now are in an era where there are a significant number of compounds in various stages of development targeting these different genetic loci, C9orf72, progranulin, and tau, and using a variety of mechanisms ranging from antisense oligonucleotide therapies to gene replacement in the case of progranulin mutations where it's a straightforward haploinsufficiency, to antibodies for tau, and so on. The AL001 trial, which is a trial of sortilin and focused on C9 and progranulin mutation carriers, just recently the development program was just recently granted FDA breakthrough status, and so there's going to be a much more intensified activity to develop that. The transposon trial, which ended recruitment last year, has just recently reported positive results, and so we'll see what happens next in that development program. Most of the rest of these are still in phase 1 and phase 2. We are about to start up another trial that's focused on progranulin here at Hopkins. Generally, these trials are using a modification of the CDR, the clinical dementia rating, as a primary outcome, alongside other outcomes. But we are looking at, there's also quite a bit of effort gone into biomarker development, because we need ways to measure treatment effects in people who are asymptomatic. What you're looking at here is the best candidate that's been identified so far, neurofilament light chain, or what we call NFL. And what you're seeing is that it becomes elevated. You're seeing two things. Firstly, that it becomes elevated in people who are symptomatic even before they have dementia. Secondly, there's considerable overlap with people who are normal. So it's not really we don't anticipate that it will be a good classifier. People have made efforts to try to examine it for clinical staging, and you see more of what I just mentioned. This is data from the all-FTD study looking at familial cases, samples from familial cases, and showing again that when you look at what was called MBI, or mild behavioral impairment, versus MCI, there is a slight uptick, but not a clear separation from asymptomatic carriers and from normal non-carriers, and that the levels get even higher in people who have overt dementia. We don't believe that this will be a classifier, because as you can see here, if you look at the bar graphs, even normal non-carriers, some normal non-carriers have higher than expected, regardless of the cutoffs that you're using. So you have a low cutoff, high cutoff. Some normal non-carriers still have higher levels than you would anticipate. There is some preliminary data suggesting that some psychiatric conditions feature elevated NFL. And so more work is to be done to classify, basically we're going to need more than this. NFL also is not looking like it's something that we can use longitudinally. As you can see, the longitudinal trends do not allow us to be confident that it's a reliable measure of either illness progression or treatment response. This is mild, it's very mild. We're beginning to focus very much on how to define the transition from normal to symptomatic, and how to, in order to improve clinical recognition. She had a hard time pinning down the diagnosis. She didn't go into that. But there was some difficulty. There was some difficulty even with the disability process because of the subtlety of the presentation. And this is not an uncommon story. This panel shows that even years before the estimated age at onset, there's the atrophy in the frontal, anterior cingulates, insular cortex, temporal cortices are steeper than, say, in the occipital and parietal cortices. And there have been efforts now to define what is called mild behavioral cognitive impairment, FTD. And overall, and this is basically using features that are typical of FTD: apathy, disinhibition, irritability, loss of empathy. I've boxed out the numbers that matter, which is the sensitivity, the specificity, in both the development group and the clinical validation group. And what you can see is that sensitivity and specificity are still not quite where we would need them to be, especially for a low prevalence condition. Now, in the GenFI cohort, they've gone further and included motor impairments in their early motor impairments. And, Dr. Triplett asked about that in his interview. Early motor impairments in the phenotype, because some of these cases actually start out with motor dysfunctions, particularly those that will go on to develop ALS, or those that will go on to develop PSP or CBD. And those criteria are also not performing very well. They're not performing very well, as you can see from the panel. Even when you shrink the group to data from within 5 years, to those who are within 5 years of the estimated age at onset. So sensitivities and specificities are still unsatisfactory. Now, when you combine the clinical criteria with NFL and with an atrophy measure, then sensitivity and specificity improve considerably. And so we're working on disease progression models to try to combine these data in stochastic modeling that can allow us to be more precise about disease progression. We will need larger samples ultimately. We're going to need larger samples, and work is in progress to unite FTD cohorts around the globe. And you can see a list of all the cohorts that are being pulled together. So FTD care, whether it's for sporadic cases or for familial cases, is multifaceted. Today we're in the space of ameliorative treatment, sometimes using medicines for neuromodulation, increasingly using brain stimulation methods, doing that for neuromodulation as well as for rehabilitation, and of course for palliative care. Where we really want to be is all the way to the right, where we're curative. The pharmacologic interventions also mirror what we know about, what we're familiar with in psychiatry, treating anxiety, depression, things of that sort. Sometimes with caution, for example, where there's Parkinsonism, you have to be careful with neuroleptics and so on. Genetic testing, which is the thing I'd like to highlight before we stop. Genetic testing, there are guidelines that have been made explicit. So it's generally recommended that you don't pursue genetic testing. It has traditionally been recommended that genetic testing be pursued only in the situation where there's a 3-generation pedigree. But we're recognizing more and more that there has to be some flexibility with this. There's a distinction to be made between pre-symptomatic or pre-diagnostic or predictive testing versus diagnostic testing, which you're doing in someone who already has symptoms. The predictive testing is not recommended in minors. It should be done. It should always be done after genetic counseling, and there should be psychiatric support to follow afterwards. the local experience is that we're now in this, and this is nationwide, we're now in the era where we have patients and we have what we might call patients in waiting. Increasingly, people are seeking genetic testing because of the progress that is happening with clinical drug development. Also, with the advent of sites like 23andMe, we're beginning to encounter people who've already done the testing and are coming to us to use the test results. And so we are in a situation now where we're beginning to see a number of people who in the clinic, but also we have a considerable number in follow-up, and you can see in the slide that we are seeing, we have a number of people who are asymptomatic, who are symptomatic in clinic and in research, who we're monitoring. In some cases, it's research participation, it's clinical care for other conditions like anxiety and depression. It's clinical care in asymptomatic carriers for psychiatric states. But we also have people in clinic today for surveillance, people in high-risk professions who want to be monitored. So the challenge is that there is increasing interest in this. There's direct-to-consumer genetic testing, and attitudes regarding genetic testing are not quite, among providers and with the public, are not quite where we would like them to be. I'd like to close by talking about the unique benefits that we've had and the unique circumstances that we've had in being able to advance this work in the field. There's tight coordination. First of all, there's a registry. That's what you're seeing there. There's an FTD registry, and we're beginning to identify people who are we're beginning to capture people who are self-identifying as either mutation carriers, relatives, or caregivers, people who have FTD or are affected. But there's vibrant multi-stakeholder collaboration with academia, policymakers, industry, and of course with clinical care and advocacy groups. And there's an emergence lately of advocacy organizations founded by people who are living with these mutations who are asymptomatic. So there are organized groups for C9 mutation carriers now, for progranulin mutation carriers, and just recently also for tau mutation carriers. So there's a lot of positive work that's been going on. I'll stop here. I believe I should save time for some questions. But I'd like to say my thanks to all the people that have been very instrumental in the work. Anne Fishman has been here with our group the longest, our research staff. She's phenomenal. Seema is a nurse practitioner. Chris Morrow has been working hand in glove with me, and Michael Bray has just recently signed on to work with us. And there's so many others, too many to mention. Vidya is in the back. She's been also a very close collaborator for so long. So thank you, everyone. Thank you for being here.
Well, thank you, Chiadi. That was wonderful.
Thank you.
And so since Jimmy's not here, I get first dibs on questions.
Yes, you do.
So, and sitting there, I was struck. I did a geriatric fellowship here, we'll call it 20 years ago. It's amazing to me how far this has evolved, how much it's developed. Taxonomy has rearranged in a lot of ways. Yes. And I realized, too, a lot of what I was taught was frontotemporal dementia were usually people who were very severely affected and almost in stereotyped ways. The disinhibition was profound. The language problems were, you just knew what you were seeing. But it made me think we're probably missing an awful lot. So I'm just curious, what advice do you have for us in the clinical realm to be thinking about? And there's a two-part question, I guess. Just because I want to make sure I get the questions in. Do you find that clinicians are overly dependent on imaging, particularly PET scans, in making these diagnoses? Because I was struck that her imaging, I think it was a PET scan, just showed decreased uptake in the parietal lobes, which I found kind of interesting. But anyway, I just wanted to hear your thoughts and your advice.
Yeah, absolutely. Thank you. It's a terrific question. So diagnostic delay has been an issue, on average 3 to 6 years. I had the slide in, but I took it out so that I wouldn't have too many. The formal diagnostic criteria specify that to get from possible to probable, you have to have focal atrophy, the condition. But now that we have these biomarkers, we're beginning to get a better glimpse of what you might call the cases that don't exactly follow the stereotypical presentations we're talking about. I think what this means really is that these biomarkers are coming, and they're going to revolutionize our ability to make diagnoses for the better, and also our concepts of what a case is. And maybe even our case, and probably our case definitions will have to be revised. Turns out that people have looked at the sensitivity of the formal diagnostic criteria, and they're not particularly good when they've been put to the test, but they've been accepted widely and are still being used.
Great. Thank you. Dr. Tobolowsky.
Yeah, I'm curious about how much of the cost are patients consuming with regards to genetic testing for these conditions?
The cost of genetic testing. It used to be expensive, not anymore. Many insurers will cover, and also there are many, many more options now. It used to be that you had to go through Athena or Quest. Now there are actually academic centers that are offering genetic testing. There are startup programs like Invitae, Centogene, and they offer testing for a fraction of the cost. And they save samples, so you can actually revisit the sample at no cost in the event that there's new mutation discovery if previous testing was negative and the family history is compelling.
Yeah, you mentioned in your talk as a depression doctor, high-risk depression. Tell me what you mean by what are the high-risk depressions? If I heard you correctly, that might suggest that we're headed in this direction.
Sorry, the high risk?
Did you say, I thought you mentioned that there were high-risk depressions. Maybe not.
No. I don't think I did.
I wasn't, well, let me just add, I've certainly seen a number of older patients with older onset, either depression or older onset conversion from unipolar to bipolar illness. And a number of them turn out to have neurodegenerative disorders like PSP. And I just wondered if that's something that is going to be fitting into this construct down the road.
Yes. So there have been a number of reports of, for example, Parkinson's disease, and Chris Moore and I were recently involved in a case of the kind where there is this idea that we might be looking at a very early presentation of Parkinson's disease. Parkinson's disease sometimes presents with anxiety, with intractable anxiety or depression that goes on for several years before it becomes clear that this is neurodegenerative. We've seen that with FTD, we've seen that with Alzheimer's disease as well. So yeah, sometimes it is a prodrome, or the change of the behavior of a pre-existing affective disorder is a signal of a prodrome.
I think you mentioned one of the cases started as a severe depression.
Yes. Okay, yeah, that may be what it was, yeah.
Dr. Franklin.
You mentioned that you've only about 10 patients that have risk factors that you want to see in a certain thing. Are those observational studies that the patients are following?
Observational and clinical trial. The ones who are in research, yes. Osman.
It's me.
Oh, okay.
Thanks, Dr. Onyike. Can you talk about the role of family members, especially when it comes to research and diagnosis?
Yes, it's a great question. In neurodegenerative, in this space in which we work, and I think in some cases this is similar in child psychiatry, for example, you often find yourself with a client and a patient, and they're not necessarily the same person, because in the case of children, we know why. It has to do with maturity. In the case of neurodegenerative diseases, as they progress, they erode people's autonomy, and often people also are unaware. So we need their help in putting together care, in understanding what is going on in the first place, in understanding, getting the history and the chronology, and getting tests done, getting interventions to stick. So it's very much a partnership, and you're very reliant on the caregivers. Now, there's caregiver burnout is a problem. Chris and I are just beginning to look in more granular ways at caregiver burnout in frontotemporal dementia, because if we can identify factors and subgroups, we might be able to target intervention more accurately.
All right. I think we're at the hour now. Thank you, Chiadi, for a wonderful grand round.
Thank you.